for the next talk. She will be taking us through top 10 clinical pearls to avoid misdiagnosis in ocular surface tumors. Over to you, Dr. Anasua. She is a renowned ocular oncologist and oculoplasty surgeons from Vijayawada, LV Prasad Eye Institute. Over to you.
Good morning, everyone. So, as I just said, I will be helping you differentiate the wolf in sheep's clothing in a busy OPD. So, I will be taking you through cases which were misdiagnosed and referred to us. So, this first case was referred to us as a case of limbal stem cell deficiency. So, this was at day 1. A 28-year-old gentleman diagnosed as limbal stem cell deficiency post chemical injury was started on topical steroid. The patient again presented to his ophthalmologist at day 21, and what do we see here? We see a sterile scleral melt for which his ophthalmologist did a scleral patch graft. Day 28, the scleral patch graft melted, and it was at this point of time the patient was referred to our ocular oncology clinic. So this is the same patient at 10 months and 2 years. The patient denied, was it complete denial, and he refused the enucleation at this stage. So what is this case? So this is a typical case of a nodulo-ulcerative OSSN. So nodulo-ulcerative OSSN, although this morphology is very rare, but it is an extremely aggressive type of OSSN. So what do we see in these patients? We see an area of conjunctivoscleral dehiscence. What we need to focus on is the surrounding conjunctiva, which is indurated and has feeder vessels. The adjacent cornea usually has this corneal haze. So this is a typical presentation of a nodulo-ulcerative OSSN. You can go ahead and take a biopsy from the surrounding conjunctiva, which gives away the diagnosis. So the first clinical pearl is localized ulceration of conjunctiva and sclera surrounded by indurated thickened conjunctiva with prominent vessels. Think of a nodulo-ulcerative variant of OSSN. The second case was referred to us as a case of conjunctivitis. 67-year-old female, unilateral conjunctivitis, non-resolving on topical antibiotics in 6 months. So what do we see here? It's a intumescent mass on the ocular surface. You can see it is covering the entire ocular surface. So it is a case of diffuse OSSN. So unilateral chronic conjunctivitis, always rule out a diagnosis of diffuse OSSN. The third case referred to us as viral keratitis. So she was a 75-year-old lady, was complaining of a curtain-like sensation on her eye since 3 months. She was diagnosed as HSV epithelial keratitis and started on acyclovir eye ointment. But what do we see here? There is a sheath of cells on the cornea, and you can see the edges. They have fimbriated edges. So this is how a typical corneal OSSN presents. You can further go ahead and do an ASOCT to confirm the diagnosis. You can see the epithelial thickening, hyperreflective epithelium, thickened epithelium with an abrupt transition. So after 8 months, the patient was disease free and with the use of topical interferon. So the pearl here is conjunctival and corneal OSSN. They have different morphology. We need to note the edges. The edges are either fimbriated like this or heaped up like this. Retroillumination gives a better idea of the extent of the lesion. Like you can see here, the fimbriated edges are nicely brought out by retroillumination. So conjunctival and corneal OSSN are different in morphology. Edges in corneal OSSN are either fimbriated or heaped up in appearance. Diagnosed as non-resolving microbial keratitis, 55-year-old seropositive lady, right eye pain, discharge, decreased vision since 25 days on topical antibiotics. What do we see here? So there is a limbal mass here which was missed by the primary ophthalmologist. So OSSN can coexist with microbial keratitis. So we have published our series and we have suggested a protocol-based management where basically we need to look into presence of corneal perforation and intraocular extension, and based on the visual potential, we plan the treatment. Again, referred to us as OSSN, but this is a young patient, and it's she has bilateral lesion, bilateral gelatinous masses, limbal masses, and there's a history of itching with eye surface mass since 3 months. So on everting the upper eyelid, this is what we see, cobblestone papillae. And this is the associative picture where you see a subepithelial, predominantly subepithelial lesion, and there is this epithelia dipping into the lesion, which is typical of pseudoepitheliomatous hyperplasia. So this was a case of pseudoepitheliomatous hyperplasia in allergic conjunctivitis. So history or signs of ocular allergy, young patient, think of pH, evert eyelid in all cases, and start the patients on topical steroid. Again, a patient diagnosed as OSSN, history of pterygium surgery 2 weeks back. So a typical case of pyogenic granuloma, pedunculated, red, fleshy, richly vascular, bleeds on touch. So history of trauma, surgery with a vascular pedunculated mass, think of pyogenic granuloma, start patient on topical steroid. Again, diagnosed as OSSN, what do we see here? 16-year-old female. It is, the lesion is subepithelial. So ASOCT is, like whenever in doubt, ASOCT is extremely helpful in our clinics. So this is nothing but a pingecula with inflammation. So pingecula, pterygium, they are subepithelial lesion versus OSSN, which is epithelial. Again, a case referred to us as OSSN. What do we see here? Smooth, diffuse, slightly elevated, salmon patch appearance, hyporeflective subepithelial lesion. So a typical case of lymphoma, conjunctival lymphoma, pink subconjunctival mass, think of lymphoma. Again, referred to us as nevus. What do we see here? Dr. Chintar had showed a similar case. Don't miss this keratin there. So pigmented OSSN, it is very common in our population. So whenever you see surface keratin, we need to rule out the diagnosis of ocular surface squamous neoplasia. Referred to us as conjunctival melanoma, because there was rapid progress in the past year and there was a new blood vessel which has developed. So this is a typical case of a nevus, because it is, you see the cyst, it is limited to limbus, variable pigmentation, and there can be change in size at puberty. Feeder vessel does not rule out the diagnosis of nevus. So they have 1 in 300 risk of, just 1 minute more. So limbal pigmented lesion with cyst, think of nevus. And how do we differentiate them from melanoma? So melanoma, again, you can see here it is going beyond the limbus, so there is corneal involvement, there is a thickness to it, and there are thick feeder vessels. Don't miss the surrounding melanosis there, because majority of the cases arise from a pre-existing PAM. So surrounding melanosis, corneal involvement, think about conjunctival melanoma. So again, this was a very funny case. So this particular patient was referred by a cornea colleague. So they, on table, they deferred the cataract surgery because they wanted us to rule out conjunctival melanoma. So what do we see here? It's bilateral, symmetrical, flat, perilimbal, cobblestone pigmentation with microfolds, which you see here. Fine pigments on peripheral cornea. There can be fornix extension, usually in dark-skinned patients. So it is a conjunctival associated melanosis, or what we earlier used to call as racial melanosis. There is 0% risk of conversion to conjunctival melanoma, so cataract surgery can be safely done. Flat, perilimbal, symmetric, bilateral pigmentation, think of racial melanosis. The last case, referred to us as nevus, a child, but what do you see here? So this glistening appearance is there, and it is going into the cornea. So this we further probed. There was a history of injury with pencil. So this is nothing but graphite at the limbus and also in the stroma, as we can see in the associative picture as well. So we need to note the features of OSSN, the typical ASOCT finding which we have already emphasized. And we need to differentiate nevus, racial melanosis, and primary acquired melanocytosis in our clinic. Thank you everyone for the patient listening.
Very nice presentation, Anasua. Brings to mind a case I had, a lady post-operative cataract, and she had a diffuse OSSN involving the palpebral conjunctiva as well. For I don't know for what reason she was put on cycloimmune. And the OSSN did map biopsy, observed her initially, did a map biopsy and proved it to be an OSSN, a very superficial one. And for some reason she didn't stop her cycloimmune, and all the alpha interferon and everything we were putting, because it was too diffuse, even the fornices and please sit, please sit. So it was really like, I mean, I don't know why they, so this is a thing that when you put cycloimmune for any cause, on the in the anterior segment or in the corneal cause, you have to be, because I thought it reduces the local immunity and can predispose to an OSSN, because we know that they're predisposed to by immunity, lack of immunity. So I don't know if anyone else has any such experience and would like to know. She's lost to follow up now, so I don't know what happened to her, but she was coming to me for 2 years and she continued the cycloimmune. I do not know why, in spite of telling her repeatedly, and the OSSN wouldn't go away. Correct. Correct. So I think we have to, a word of caution when we use cycloimmune, follow up the patient and look for things. Of course, she was an older person, so maybe in older age it is common.